Sure, I have to follow that. How do you, Dr. Martini, which one advances it? The one on the right here? Whew. I don't dance. However, so good afternoon. My name is Dr. John Silver. I am not a DMP, and obviously my color is self-evident. But I will say that in my mind at least, I am a pure nurse. I bought into the code of ethics. I bought into the words, all the words we toss around. Last time I talked to you, I talked about the system design that would give us the best opportunity to meet those goals, to reach out into every community and provide the care we should be providing. So anyway, I have two things to say first. The example I use in my slide, or my presentation, is that of a hurricane. So if I'm going to cause PTSD to anybody, I apologize. This was done long before Helene and Milton, although I come from South Florida, so I'm no stranger to hurricanes. The other thing is the model I'm going to talk about is based on the work by Janet Hagberg, who produced a book, or wrote a book in 1994 called Real Power, Stages of Personal Power in Organizations. When I started my Ph.D. work, the two kind of questions I had in my mind was, what's wrong with healthcare and how do we fix this? But the other question in my mind was, why can't nursing control its own practice domains? So these were two big drivers. In terms of the system design, I did not see any answers coming from public health after my MSN. I didn't see answers coming from medicine. And unfortunately, I didn't see answers coming from my own field. So I stepped out of healthcare completely from my PhD work and got what was called, and please don't laugh, the Public Intellectual PhD in Comparative Studies. It was a brilliant program. It let me look back at healthcare, grounded in my nursing, from multiple disciplines, to be able to see if maybe there was something I couldn't see, or other people weren't seeing that I could see as what I now call myself an applied philosopher in terms of healthcare systems, healthcare system design. So I did want to get those out. I have many conflicts, but no potential conflicts related to presenting here. So there's my hurricane. Sorry about that. So I use the hurricane because it is one of the most powerful forces in nature. But hurricanes just don't pop up. They develop over time. They start with, storms, and then they come into depressions, and then they become tropical storms, and then they evolve into hurricanes. And the real power of the hurricane is when those bands wrap around the eye of that hurricane. And this is when the storms intensify and become the monsters that we just witnessed. So I want to present a challenge to you, and that is the nursing to me was designed to be a socially active force. When you come into my office, you will not find a picture of Florence Nightingale on my wall. You'll find a picture of Lillian Wald. I'm grounded in people like Mary Seacole. And the reason I find Seacole as a great contrast to Nightingale was that Nightingale was waiting for patients to be brought to her to provide the excellence that we provide as nurses. Seacole went to where they needed help. And that, to me, should be the mission of nursing, to find people that need our help and then help them. So I just wanted to clarify that. And too many communities in our country are deprived not just of nursing, but of healthcare in general. Minority communities, but lots of communities, rural communities. In Texas, for example, 40% of the communities don't even have a PCP. Forget nurse practitioners, they have absolutely no access. And then when you put the demands of rural and a lot of inner city areas together, especially those that are economically deprived, there's very little or it's very difficult to access healthcare services. We also have to look at how health systems, and I hate to use that word with what we have now because as Walter Cronkite famously said, the US healthcare system isn't healthy, it doesn't care, and it's not a system. So there's that. So the eye of this hurricane that we call nursing, that I would like to see become that category 5, is all our values that we have, the words we talk about, equity and racism and justice, all the core values that we hold as registered nurses. The bands around it are the army of nurses that are out there. There, for some reason, and I'm not quite sure why, it's multifactorial, nursing got dragged into this training people for hospital mentality in the 1900s. And we're still mired in that. You know, we're not becoming hospital nurses, we're becoming nurses. And that can be a broad range of applications, not just hospital trained. One of the big tensions nowadays is hospitals are complaining about the students that are coming out of nursing programs. You know, I keep trying to tell them, look, we train students to fly a Cessna safely and competently. You get them and you want them to be able to fly F-18s because the demands that you put on nurses in these facilities are just overwhelming. Now, normally, we would expect that our professional organizations would be leading the charge to defend us. But the simple fact of the matter is they don't. The ANA, in my opinion, has been a massive disappointment to the field of nursing. So what I want to talk about today a little bit is us as nurses expanding our view of what nursing is so that we can start getting the organizational power we need to be able to implement political power. Now, a lot of people think of political power as a dirty word. I prefer to think of it as political effectiveness. So the ability to go in and get your agenda not just brought up for discussion, but actually passed and enacted. And that's a big different thing. We have some 800 nursing organizations out there. All of them have a little piece of the cracker that they're working on. Sometimes they put names on it, you know, Nurses for Justice, Nurses for Equity. But what you end up doing is working at a process level, and that process level is only going to respond to the system demands that are put on it. So you can have a wonderful idea and take that into your community, but if you can't get finance for doing that because insurance companies won't pay for it, or you can't get support from the system, again, in quotation marks, that's in existence, then how do you sustain that movement? How do you become a role model for communities across the country to be able to implement that? How do we talk to each other? There's really not even a medium for us as nurses to talk to each other. I've tried to publish for 2 decades in nursing journals, and what I get is, because I'm talking political issues, that they don't want to publish it. I do manage to get into some interdisciplinary journals. Same thing at presenting at conferences, and God bless Dr. McCamey and the group here at DOC, because in my model, you all are the alpha predators. You are who we've been waiting for over a century. Nurse practitioners, and then the DNP level of authority and knowledge is what we've been missing. You are the missing band in that hurricane. Now, but there's other missing bands too. There's over 4 million of us in this country. That's a pretty good chunk of political power because that's votes. But again, how do we talk to each other? We don't even have a professional association that will come out and support a particular candidate. They're afraid to become political, and yet we live in this political world. So what I want to talk about is how do you become politically empowered or politically effective? So Janet Hagberg, not a name that I'm sure many people know, wrote a book in 1994 called Real Power: Stages of Personal Power in Organizations. When I started my doctoral work, what I found out was there are no models for how do you become socially empowered. There really are none. We've had spontaneous movements come up. You know, the gay marriage rights, for example, is one example of that. We had the kind of tsunami of particularly black issues that came up in the 1960s where we got Voting Rights Act passed. And yet look what's happening now. They're starting to fracture and tear these things apart in our country. So, where am I at here? Oh. So the Hagberg model, and what I did was I tested this model against the experience of the California nurses as they got staffing ratios passed in California. So when I started my dissertation looking at becoming politically effective, I had to find something, and I wanted to keep it grounded in nursing, something that had happened where an organization of nurses had managed to actually become politically empowered to the point where they could have an effectiveness in getting legislation through. So I went out and interviewed 16 of their original leaders, and I looked to try to find a template that I could present to nursing groups around the country to say, hey, this is a strategy for doing this. But again, you're doing a dissertation. Is anybody here a Ph.D.? I'm sure there's tons of them. You have to contribute in some way with an original model design. So I found Janet Hagberg's model of organizational empowerment, and I tested that model to see if that would work for nursing organizations. Now, in the Hagberg model, you have to go sequentially through all these steps. So all of us, in a sense, start out with powerlessness, and then we have to migrate up to become politically empowered. Are you flashing me a sign over there? 5 minutes left? Oh my God, I'm gonna have to talk fast. All right. So what I found out was you do not have to go sequentially in progress. The power of purpose, the value of the power of purpose is it can drive membership. And if you watch The Tipping Point, or you've read the book The Tipping Point, what you find out is when you develop a critical mass, that purpose can then spill out to where you become politically effective. It's a good thing I don't have a lot of PowerPoints. Our biggest strength is our numbers. It's not just our ideas. But we need to align the message to appeal to the numbers, to bring them in so that we get the support and the political support, so that when we walk into these politicians' office, it doesn't matter that the person walking out the day before gave them $50,000 for their campaign funds. What matters to them is we represent 150,000 votes in their districts. That's political power. So first thing we need is a clear vision of what we all want. And to me, that's kind of what's been lacking. We have this kind of fractured look at, is it Medicare for all? Is it value-based care? Is it direct primary care? None of those things are going to work because they're all process-level interventions. And we don't want to put something in place where you have to pay even more if you want to be able to access primary care, for example. The other thing we have to be able to do is go talk directly to the American public. Nursing is not good at that. We do not have the advertisements, and you'll see this periodically when AHA is out there running commercials around the country. Anytime industries start getting threatened whether it's the drug companies, no offense, I know we have drug company sponsors, or the hospital association, or medicine. You'll start seeing these commercials. In medicine's case, you'll start seeing TV shows migrate in about, doctors. So we need to figure out a way to A, communicate with each other, B, come up with some kind of central idea we can get behind, and then take that message to the American public directly. Now, I hear all the time, nursing's the most trusted organization in the country. Really? What nurses? Nurse academics? Is that who the American public thinks is the most trusted profession in the country? Nurse managers? Is that who it is? No, the American public knows who. The nurse at the bedside, the nurse in the clinic, the nurse in the hospital that took care of them, the nurse that's in the community doing the work. That's the nurses that we need to entrain into us as a professional organization, not just rely on the 4% membership of the ANA we have now, for example, which is largely academic and leadership nurses. So if we want an organization, and this is the message from California, if we want an organization that does what we want them to do, we have to take over that organization, because the organization will then do what we tell them we want them to do. I think that's it. Any questions? If you have it answered. Well, you're right here.
You're right here, but I need the mic. First, I want to really reiterate the importance of what you said, that we need to stop the pipeline focusing only on hospitals. We need to diversify and change the mindset that primary care happens at home, and nurses are an incredible workforce to help prevent our patients from getting sick, keep them out of the hospital, and that model is a capitalist model. It's not working for us. So thank you, I agree 100%, and I think that there's a great opportunity to really bridge those relationships with schools of nursing and community health centers, and it's just, there's a pathway to get there, and then we need to kind of think outside the box, not the ongoing pipeline of just that one way of feeding that model.
Yeah, and it's not just that all of the academic disciplines have become siloed. We've become siloed. What is nursing? Is it just DNPs and NPs and BSNs and ADNs? And why has the ANA been attacking the ADN level? If we're going to hold ourselves out as a socially active force, should we not ourselves be a socially active force? The school I teach at is not a huge university. I gave that up. It's a smaller school. We are 94% minority students in that school. Our students face enormous challenges, and yet we have 100% pass rates. Yes, sir.
I just have a quick question. You do bring up a good point about how we can drastically influence politics. And I think that's a very imperative piece that we all need to be aware about. So what platform can we use to bring everyone together? Or what kind of style of or what kind of incentive? I don't know. Do you have any ideas on what we can do? Because we're everywhere, but.
I think what we see here with DMPs of color is one example of what we can do. So we can empower an organization who can then be perceived as kind of a leadership organization. Point, yeah. But it has to be focused not just on DMP level of practice or NP. When you look at who should be in that organization, it should be the DNPs, it should be the NPs, it should be BSNs, it should be ADNs. But it should also be community health workers. It should be people going into homes. It should be family caregivers. When you can get that kind of coalition together, you have enormous political power.
Right. Thank you.
Certainly.
Thank you.
Uh-oh, I'm in trouble now.
Dr. Ali Tayeb. So a couple of things, and this is more of a statement than a question, and please feel free to disagree. So I work with an organization that is a FQHC, one of the largest in the nation, primarily serving Hispanic populations. Probably 90% of the population they serve is Hispanic and Black. The population that works at with 5,000 employees, about 75% of their employees are Hispanic, Latino, Latinx. So looking at that, and they have a strong political arm, and this is something that they do well. What they do is they put their physicians through a 2-week course before they make their way to, and I'm out of California, before they do their day in Sacramento, before they do their day in DC, and actively go out. Nursing does not do that. We are not training our people to go to the politicians and advocate for nursing. And when you hear those physicians advocate, I have never heard, and I've been a fly on the wall while they're going through their program, and what they do is they don't talk about, as a physician, I need X, Y, and Z. What they do is they say, as a physician, this is what I can do for your constituents in the community. So in order for you to serve your community, we need this for your community. I've heard nursing talk to politicians, and they say, we need more nurses, we need more pay, we need this. They don't usually talk about what they are doing for the community and what the outcomes are. So we need to become more savvy as an organization or as an institution on how we can actually convey our message in a way where politicians are receptive and they see the benefit really for them, because we're trying to influence them to do something for us so we can influence the community in return.
Well, I wouldn't say all nurses. So my group, Nurses Transforming Healthcare, has been endeavoring for 2 years to get into communities. We have a current project we're launching called Flip Your Zip. And what we found out, or what I found out in doing the study, was after reviewing multiple public health assessments, what I found out is they're largely allopathic based. And the outcomes are all measured by hospitalization rates at nearby facilities or whatever. So what I decided was that is not what defines a healthy community. A healthy community is not how many COPD or type 2 diabetes cases you have. A healthy community is also a sense of optimism. It's also a sense of engagement with the rest of the country, the rest of the world, as an equal, not as a, here's a handout for you. So I reached out and found out that we need a new community assessment tool. And the one I picked was from University of Colorado. A friend of mine, Dr. Gene Watson, designed a caring-based community assessment tool. So I think there's multiple things we need to change in this. And one of them is the information we get out of communities, so that interventions that we apply in, whether it's mobile MP units or fixed facilities, or rotational services, whatever that might be, is both data-driven, and we have a partnership with that community that understands what we're going to be bringing in, that is wanting to use those resources, so that we're not just walking in with an allopathic menu and saying, here, take one from column A and one from column B.
Yeah. Also, from looking at it, not everybody is going to be engaged with those community-based organizations. So the thing that I should be able to go to my representative's office and have talking points, and I think this got brought up yesterday, is as a profession, we don't have talking points, right? We don't all have the same talking points that we can speak. That's the piece that we need. I think from anybody who's in the academic setting, I think it's important that we start talking about those.
I did two internships in Washington, and what amazed me was I'd go in and talk to a representative or a senator, and I'd say, this is what we kind of would like to get accomplished legislatively. And he'd turn around and say, well, 2 days ago, there was another group in here of nursing leaders that were saying just the exact opposite. And 20 minutes before he came in, some guy walked out the back door that had just given me $75,000 for my campaign. Who are they going to listen to? And we have structural problems. We have for example, there's only 27 states, I think, that have NP independent practice. California is not one of them. How is that even possible? They're the most progressive state in the country. But what we find out in a lot of states, whether it's Kentucky or we go to Texas, we find out that physicians have strategically positioned themselves in these legislatures to block these scope of practice issues. In fact, it is the #1 agenda of the Texas Medical Association. I know because I read their meeting minutes. The #1 agenda is blocking scope of practice issues. So, yes, we have obstacles, but politicians also like their jobs. And if you can threaten their jobs, and that means activism, going into their districts and taking them on head on, and you don't have to spend a ton of money, AM radio shows, benches, bus signs, all pointing the finger at that politician as to why the cost of health care is so much and why they don't have access to the services they need. It has to be that kind of ground warfare. Any other questions? Oh, I have somebody coming down. Am I late? Oh, I'm sorry, I'm late. But I'm available.